Hi, my name is Nabila Sharif, and I am a fourth-year medical student at the University of Tennessee Health Science Center. I'm presenting a case of subcutaneous emphysema and Stenotrophomonas Maltophilia empyema. Stenotrophomonas Maltophilia is a multi-drug-resistant organism that is rare to be found in the pleural space. Here we present a case of a Stenotrophomonas empyema. We have a patient who is a 33-year-old female with a history of recently diagnosed bilateral pulmonary embolisms, left ventricular thrombus, and new-onset heart failure with reduced ejection fraction of 15 to 20%, as well as cocaine use, who presented with worsening shortness of breath for the past 2 days to our emergency department. CT of the chest revealed a right-sided pleural effusion with loculations and infiltrates in the right lower lobe. Thoracentesis was performed and showed exudative fluid. Initial pleural fluid cultures were negative, and the patient was placed on broad-spectrum antibiotics. A chest tube was placed, and TPA Dornase was administered through it. A repeat CT chest several days later showed a large cavitary pneumonia in the right lower lobe. The patient was taken for a possible video-assisted thoracoscopic surgery. However, she became hypotensive and was too unstable to tolerate the procedure. Therefore, another chest tube was placed in the OR. Pleural cultures from the OR chest tube grew Stenotrophomonas Maltophilia. The patient was then placed on trimethoprim sulfamethoxazole, or Bactrim. The second chest tube from the OR was also complicated by subsequent pneumothorax and the development of subcutaneous air. The patient had 2 pigtail catheters placed in the right thorax, one for the pneumothorax and the other to drain the empyema. TPA Dornase was once again used to facilitate drainage of the empyema. The patient developed hyperkalemia secondary to Bactrim and was switched to minocycline. She improved on antibiotics when was discharged home on oral antibiotics with close follow-up. Stenotrophomonas Maltophilia is a gram-negative bacteria that is recognized as a multi-drug-resistant organism. It is thought to be nosocomial, however, there have been community-acquired infections as well, particularly in those who are immunocompromised. The more common infections seen with this bug include pneumonia, soft tissue and skin infections, GU infections, as well as bacteremia. Infections of this pleural space secondary to Stenotrophomonas Maltophilia are uncommon, and they are associated with an immunocompromised host or with instrumentation of the chest. A review of 45 patients found an association of Stenotrophomonas and prolonged chest tube use, while another review found an association with chest tubes and bronchopleural, esophagopleural, and biliopleural fistulas. The workhorse antibiotic for Stenotrophomonas Maltophilia infections is Bactrim, or trimethoprim sulfamethoxazole. Minocycline can also be used as an alternative antibiotic if patients are unable to tolerate Bactrim or have a contraindication. Infections secondary to Stenotrophomonas Maltophilia have a high mortality rate if they are not treated promptly. Stenotrophomonas Maltophilia infection should be considered in patients that are immunocompromised or who have had recent instrumentation of the chest, such as a chest tube. Quick recognition and treatment of this bug could improve patient outcomes. Thank you.